Thank you for your introduction. Thank you for the invitation to talk here. I'm introduced. I'm a GP in Eindhoven, and I also working for the Dutch College of General Practitioners in Utrecht. Somewhere there is my office. It's the Domus Medica where all the doctors work together. And it's Friday afternoon. It's 3 o'clock. The fourth speaker. So I'm to ask you something. Will those people stand up who have seen a patient during a consultation last 2 weeks? Okay, thank you. No. Stay. My presentation is about guideline prescribing, and I want to ask that those people. So the next question is about: did you use a guideline during your consultation when prescribing? And then those people who didn't do that one time in the last week, please sit. Okay. Then those people who didn't do it once times a day, please sit. Okay. How often do you use guidelines during your consultation?
7 times a day.
7 times a day. The next one, please. You may sit. Thank you.
Depending on what you mean by that. But, I try to prescribe following guidelines, and I try to teach them to the students who are in my practice also. So I try to.
But I think that's intentional. And the last, please.
The last question. I use a website we have.
Yes.
That is like a summary of different guidelines.
Yeah.
I'm sorry. Our network has a website with a summary of different guidelines which we've adopted, and we use those during consultations.
And the last person?
I have a conflict of interest. I'm a guideline developer myself, but I have the guideline links visible in the electronic health recorder. It's very easy to open them, and I often do it.
Okay, thank you. So my presentation is about guideline using during the prescribing process. Those who are not interested, there's coffee there. I give an overview of my presentation. I tell you something about Dutch GPs, and the healthcare system is a little bit different. Then about digital prescribing, and I want to focus on guideline prescribing. I think the past presentations have already looked into digital prescribing and all the problems, and I think it has done a lot of work in Estonia to get that raised and working. And then I will give you a small demonstration of my practice hours last week when I saw a patient and how digital guideline prescribing works. And then what can we learn from that in Europe. First, a little bit information about Dutch healthcare and the role of GPs. We have about 9,000 GPs, 5,000 practices, 16 million people. We have a list system. One full-time GP has about 2,200 patients. We are the gatekeepers for secondary care, and it's even in the last years emphasized that we should be the gatekeepers. So there's no patients allowed in the hospital if we don't say that he can go there. And the consultations in the hospital, they were always going like this. In the last 2 years they are going like this or a little bit like this. So that system works. We have practices with assistants and with nurses, practice nurses. We have a large program of general practitioner guidelines made by our organizations. More than 100 guidelines, and they cover about 70 to 80% of the consultations. And for introducing this system, you need a guideline system. So the last person is right. How do we do the digital prescribing and communication? Just an overview, because it was thoroughly discussed in the previous by previous speakers. We have 8 electronic prescribing general practitioner information systems in the Netherlands. My wish, one of my dreams, is 3. So there must be some different systems, so some market working, but 8 is too much. And all pharmacies have an information system, pharmacy information system. Our administrative data, but only the administrative data, are linked to the health insurance data, so that gives us a lot of less work, because that's okay. Digital prescribing is 100% in the Netherlands. I thought you even can't go to the pharmacy with a paper receipt, so you're rejected, or maybe if you have a good talk about it, but it's 100%. But we started a few years earlier implementing that than in Estonia, so I think now we are on the same level. And concerning digital communication, and our digital communication is mostly push. And that's related to privacy matters, a very important issue. If you have pull, you have a lot of more privacy problems. And the digital communication with the pharmacy is over 90%, with secondary care. So I can send all my letters with information about the patient electronically to the hospital, and I get all my information back from the hospital electronically, and I can link it to the right codes in my information system. And what is coming up is that in other primary care workers, like physiotherapy or psychologists, we can communicate also electronically. And we have in the Netherlands a little bit of a mixed system of a regional system. So with the pharmacies within, say, 5 kilometers around my practice, I have 100% communication. But with the pharmacy 30 kilometers away, I have no digital communication, but it's much more complex. And we're trying to set up a nationwide system. We call it a national linking point. But that was voted down by our parliament because of privacy concerns, because then it was all push, and now we're trying to building it up, and it's rather complicated political process. That's about how digital prescribing is in the Netherlands. Now about digital guideline prescribing, because I think that is the next step we have to take. Now, our aim when implementing the digital guideline prescribing, I've written it down here. I think we should to implement the guidelines in the prescribing process, but not only the national guidelines, but also regional guidelines or even local guidelines between GPs and pharmacists. So these should be the basis, on the basis of national guidelines, with maintenance of the autonomy of the prescriber and the patient. Because I think that's a very important aspect if you implement this, that the prescriber has, when he talks with the patient, he can make his own choices, having the guidelines before him. And the ultimate goal, of course, was to improve the quality of the prescribing process, and it would be nice if it also was cost effective, because the prices of medicine, because we get older, more medicine, so can we stabilize that? How did we do that? We also had a national sponsored project aimed at these goals, so Ministry of Welfare, health services, insurances, all united with the professional organizations to get this project up. And we started a long time ago, as you see. How did we do that? We had a large set of, as I told, national guidelines, and we translated them into a formulary. We'll go into that further later. And then we incorporated this formulary in software. And we have 2 software producers. This is Prescriptor Digitalis, that's one software producer. And then HealthBase, that's another software producer. And we integrated the software into the GP information system, but as an add-on on the system. So you can buy it or not, but it is delivered with all the systems, but you can say, I don't want to have it, but it's an add-on. And then very important is to get it integrated into the GP prescribing behavior. And then vocational training with GP trainees is very important, because they want to have this information, because they don't know what to prescribe. and this helps them enormously to know what to prescribe. We built a formulary, as I told you, and that is a very complex process. And it can, the previous speaker told us that it can be much even complexer, but you have to need an indication database. So what are the indications for the several medications, the diabetes, hypertension. Then you have to do correct coding. We use ICPC in the Netherlands. You also can use ICD-10 coding and link all those things together. Then you have to translate all the therapy schemes from the guidelines into software. You have to have a prescription database, so doxycycline is first day 2 tablets, then 6 days 1 tablet. So you have to all put that in your database. Then contraindications, you have to collect them all, put them in the database, link them to all the ICPC codes. And then you have, of course, clinical rules, and most persons who know something about diabetes. If you have diabetes and asthma, it's different. If you have diabetes and cardiovascular disease, you have different medications, hypertension, and all those, that are the clinical rules for the certain comorbidities. And comorbidities are very important. Okay, that was brief theory. Now about how does it work in practice. I prepared this speech 2 weeks ago concerning this part. I had a patient before me, I think. Can I show all the audience how it works? The patient was Mr. Aert van der Keij. He's a 65 years old male, married, recently retired. Comorbidity enough, as you see, several diseases, 7 medications, and past year several long-lasting admissions in the hospital for very complex abdominal problems. And so he came to my surgery and said that he was tired of everything, no energy, nothing, the whole day sitting in his chair. We talked a lot, and we discussed therapy 2 ways. Try to get more stepped up activation, physiotherapy, but I thought he was also a little bit depressed, so we agreed to prescribe antidepressants. And I hope you can you read it from behind? Oh, okay. Yeah. And I prescribed him some antidepressants. And then that's in ICPC, it's psychological disorders 76. So I click the ICPC code P76. Be very careful not it happens again. Okay. I can better use the pointer. So this is depressive complaints. And this is the ICPC code, and this is my information system. And then I print F3, and I get in my prescription screen. And the prescription screen, you see here the code, the ICPC code, and here you see all the medication the patient uses. And what you also see, that this is the medication prescribed by the pulmonary physician, and this is the medication prescribed by the internal specialist. I have it all in my computer. And luckily, we try to promote that patients go to one pharmacy. Because then this is more easy to organize. So, and then I press F2. And when I press F2, I get into my digital guideline prescribing system. And you see here again, depression, and then this is the medication advised by the guideline. It's all here. So I can look what are the advices of the guideline. In the Netherlands you see the advice is SSRIs. And then I selected the citalopram in this case. And if I want to look at that moment into the guidelines, I can click here. This is the guideline on depression. And we have also patient information leaflets. We have about 800 situations. So I can click here, and then the patient information leaflet comes up. I can send it to the printer, or I can go to the website where all those situations are. And then this is yellow, so there are some problems when I'm prescribing this. There are some contraindications, so you can expect with somebody with 7 medications all those comorbidity. I can read about the SSRIs here, clicking there, or I can click here on contraindications and then come into information about contraindications in this patient. I come to that later. So then I select my medication and even also the number, and then I can go back to my patient file. I'm back in my patient file. Then the medication is here, the prescription is here, the number of tablets. I didn't do anything, just press, only press. And then I see here the problems with my medication. The patient uses aspirin, so I have to think about it. And he has an ulcers in the history, so okay, does he use the correct medicine? And I'm looking here, I see here that he uses omeprazole, so okay, that's okay. And if I don't know exactly what the problem is, then I just click, and I see that problems can be with this medication with higher age patients with an ulcer, and then another problem is with if patients have a low aspirin, then you get these problems. So I get the information at that moment that I want it. But if I don't want it, I don't click on this. Then, and it was already mentioned, renal function is very important. I get information about the renal function at that moment from that patient. When was my last measurement? It was in August, okay, and it was above 60, so no problems concerning prescribing this medication and renal function. And then I put it down in on the spot where the medication goes to the pharmacy, that is this. And then at the end of the consultation, this medication goes automatically to the pharmacy, and patient can pick it up in his pharmacy. And then I also see it is added to this list when I end my consultation. And the next, I don't show it here, is that if the patient picks up the medication, I can also see it, because I get a message that he has picked it up. So this is how it works in daily practice. And what you see that we have made here a decision support system. It's guideline driven, but it's also driven by patient characteristics. And I think that's very important making it work. And it's based as well on national guidelines, but also on regional. So in our region we have working agreements with the specialists about treating diabetes, and you can put those agreements in this system. And even if we have a local agreement with our pharmacist, we can put it in this system. But still, as a GP, together with the patient, I'm the driving force. I make the selections, or I make the adaptations to the system. And included is a very important National Drug Dictionary with all the contraindications and the GP guidelines and all the patient information. So it's a system covering all what I need. And of course, because there's a selection of when I prescribe the medication, so the dosage is there, the number of, when the first prescription, it's only for 15 days, so I think that improves safety. How do we work with it? That's always an important question. If you see in how many GP information systems this system is present, we can say that in about 100% of the GP systems all over the nations, this system is present. And also in the out-of-hour service systems, it's 100% present. However, we don't have data on the actual use, and we saw already here that that's a very important issue. I think that people, trainees use it a lot, starting doctors use it a lot. I practice only 2 days, so I use it a lot because I can't remember everything. So if it's more routine in your consultations, prescribing certain medication, certain circumstances, I think you use it less. If you don't have that routine, you have more complex patients with more comorbidity, you are using this system more. And what is very important is that, and I will elaborate on that further, is that the system, you mustn't use it only in your consultation, but you must use it to say, okay, we have diabetes or we have depression, what do we think about the guideline, what are local adjustments, and we have to put those local adjustments into the system, and at the end say, okay, I prescribe that many antidepressants, and what kind of depressants, and what precautions did I take, and use that as feedback for your own behavior as a doctor. What can we learn from implementation of this electronic guideline prescription system? I think that this system has a really added value. I think only electronic prescribing has added value for me as a GP, but that's to a large extent also administrative. The process is go quicker, easier. I was much impressed by the time sheet the previous speaker showed, from 46 minutes to 4 minutes time handling the receipt. But this system also gives us an opportunity to do quality improvement and take into account all things that are important for patient safety. When you implement such a system, it's important that you have a GP information system, but I think that's in most countries. But electronic communication with everybody is not necessary. You can use it standalone on your own electronic information system in the practice. And you miss some information, but you can improve by introducing this system in your own information system, your quality of care. Very important is that we teach doctors to improve the use of the electronic medical records. We have an incentive in the Netherlands that a part of what we get paid is only paid if more than 82% of our consultations is coded. And then we get, say, 20 euro cents a patient. Okay, but for 2,000 patients, it's 400 euros, okay. So we code more than 80% and then we get that money. And we have special trainings for that, and we emphasize it also in the training of the GP trainees. As I already said, it is most cost effective if incorporated in a whole system with agreements with pharmacy and with secondary care about prescription, and then implemented it, monitor and feedback. And there was a group who looked into the costs, and they saved up to 25% of medication cost to patients. And there were two things: more rational prescribing, more generic prescribing, and less prescribing per patient. Because this system, sometimes I want to prescribe something, and then the system says, you can't prescribe anything because it's not advised by the guideline. Okay, then I start prescribing it, but the next time I think, maybe I should more adhere to the guideline and not prescribe something. So that's two ways of working and saving costs. Very important is support from health authorities and health insurance companies. We are paying a little bit extra fee if you implement this system in your GP information system. And so we are reimbursed for buying and using it. Because in the Netherlands, almost all the GPs are private enterprises. And last lesson to be learned, I think, and this is very good that I'm here and I heard the stories from your country. We should learn from other countries in developing these things and implementations, because they are very, very costly to build up this software and to implement this software. Thank you very much for your attention.